going to end today by talking about some of the really challenging cases that we see in head and neck cancer. I'm going to focus on larynx cancers, thyroid cancers, and then cancers of the nasal cavity and paranasal sinuses. I will tell you that thyroid cancer is something that we all don't see very much of, and I am constantly learning. These cases are very, very challenging, especially as you're trying to discern whether we can just get away with radioactive iodine or these patients need external beam radiation. So let's start by talking about larynx cancer. So I am going to start with a question for all of us. When you're seeing a patient with a very locally advanced larynx cancer, how do we decide between larynx preservation versus upfront laryngectomy? And we'll start with a poll.
Yes.
Well, all the people, most 88%, 87% tumor invaded through the thyroid cartilage and into soft tissue is the most answered.
We're off to a fantastic start. I'm just looking to see if we get some more participants in the poll, and then we'll go over each of these choices.
Okay.
Okay, so that's fantastic. Yes, the correct answer is C. The absolute indication for upfront laryngectomy in patients really is these T4 tumors that are not just going into the inner lamina of the thyroid cartilage, but going through the thyroid cartilage into the soft tissue. These patients are very unlikely to have a functional larynx after chemoradiation, so this is why we prefer upfront surgery in these patients. Choices A and B, certainly locally advanced larynx cancers, but they're more consistent with T3 disease, and oftentimes these patients can be treated well with radiation as upfront therapy. And then piriform sinus as well, while it's extending into the hypopharynx, these patients are often well managed with upfront chemotherapy and radiation. But beyond, I think so we're all taught this, right? So tumor going through the thyroid cartilage as a contraindication, but there are other contraindications I will tell you to larynx preservation. I think the biggest one is patients who have significant aspiration issues at baseline. So if the swallowing function is not intact or not doing very well at the time of diagnosis, these patients also don't seem to recover nearly as well after upfront radiotherapy. So certainly a consideration in these patients to do larynx preservation therapy. To not do larynx preservation therapy, sorry. So here are kind of the things that I think about when I think about larynx preservation. I did say that as I said, the contraindications. Second, let me see if I can. Okay, can you see everybody? Okay.
Yes.
So as I said, T4 disease, but there's also emerging evidence that perhaps not all T4 disease is the same. And there are patients perhaps who have very low volume T4 disease, where yes, the tumor is going to thyroid cartilage, where you may be able to do upfront radiation in these patients. I would say really bulky disease is still a contraindication. As I said, compromised swallowing functions really is something that we should pause and think about. And then, when there's significant airway compromise, it is not uncommon, even in larynx preservation, for us to do an emergent tracheostomy. But if there's just significant airway compromise where there's tumor all around the trachea, another kind of concern to see if larynx preservation is the right way to go or not, or whether these patients should get upfront laryngectomy. Next question I had was, hey, what do we cover for an intact larynx, patient with locally advanced disease? Clearly, you're going to cover the gross disease, right? So whether you're using a CT with contrast, as your CT for your CT simulation or for your fusion, or if you're using an MRI or a PET, all of these modalities are going to help you to really contour the gross disease. Generally, when I think about these patients, this disease often is extending far beyond what you can even see on imaging very clearly. I think paraglottic fat invasion, preepiglottic space invasion is very challenging to see even on a CAT scan, especially a CAT scan without contrast. So, if you have an MRI, that's great. Most of us don't have access to an MRI on every larynx patient. I will tell you, certainly even in California, I don't. And so I'm generally quite generous when I give that initial CTV margin here for gross disease. So on the order of 5 to 10 millimeters. For any lymph nodes involved, I think certainly if there's no E&E, you can do very, very tight margins. So a 5 millimeter, anatomic margin with no gross E&E that's visible on a scan, and then maybe slightly more generous margins if you're seeing extranodal extension for these patients. I think the key thing really, and where I see sometimes that folks want to treat a lesser amount of volume is really in that intermediate dose cloud for larynx cancer. I think one of the key take-home points I hope you can take away is that you really need to cover the entire larynx. Even if you have a focal disease involving, say, the arytenoid and the area epiglottic fold and not the rest of the larynx, we need to cover the rest of the larynx in that intermediate dose volume. And be very, very mindful to really cover that paraglottic fat and pre-epiglottic space for these patients. If your patient has had an emergent tracheostomy, you need to cover the tracheostomy site and the stoma in these patients. And then for, depending on the location within the larynx, so if you have a high supraglottic larynx tumor, you may want to cover the vallecula. And if you have tumor really going along the area epiglottic folds or the arytenoid cartilage, you may want to cover piriform sinuses in those locations because that's going to be immediately adjacent to where your disease is. In terms of nodal volumes, I typically at least cover the involved nodal basin to the intermediate dose. And depending on how concerned I am, generally I try to at least cover the low level 2s, level 3s, and the upper level 4s in my intermediate volume dose. All of your elective nodes are going to be in your low volume dose. And this is where I think this is quite helpful for me. I never cover 1A nodes. 1B nodes, I will think about it, especially if you have a very anterior level 2A node involved. But even in the modern era, more and more, I try to not treat level 1 nodes if at all possible to be able to spare the submandibular glands. Level 2 nodes, we're always going to cover. And then the question always comes, how high are you going to treat the level 2 nodes? Are you going to stop at the top of C1, or are you going to go all the way, or top of C2, or are you going to go all the way to the skull base in these patients? If you have node positive disease on one side of the neck, for those patients, I will cover level 2 nodes all the way to the base of skull. If you don't have gross disease, so say you have just unilateral neck involvement, the contralateral neck is not involved, I do think that you can stop cranially at the transverse process of C1 for those patients. Level 3 and level 4 nodes are really the primary draining lymph node basins for a larynx cancer. So these lymph node basins always have to be covered. Level 5, very similar to level 2, the cranial part. So if you have ipsilateral nodal involvement, I'll cover at least 5A lymph nodes for these patients. I think the one lymph node basin that we typically don't cover in almost any other head and neck cancer that we really cover a lot in larynx cancer and maybe hypopharyngeal cancers are going to be your level 6 and 7 lymph nodes. Especially for a bulky larynx patient, if you have subglottic extension, for those of you that are doing fiber optic nasopharyngoscopies and are actually looking at the larynx, if you see disease going into the subglottis, and oftentimes it's just hanging from either the false folds or the true cord, you should cover the level 6 nodes. Any hypopharyngeal involvement, so if you have involvement of the piriform sinus, you should cover level 6 nodes. And the most common indications that I typically have in my practice are patients who just have very low neck nodes. So they'll have a supraclavicular node that's involved in larynx cancer. Then I'll cover that next basin. I'll cover level 6 for those patients. And then finally, tracheostomy. I will say that, in California, we don't see as much larynx cancer because our smoking rates are relatively low. But when we do see larynx cancer, we see very advanced larynx cancer here. And so it's not uncommon, even for a stage 3 patient with T3 disease, to come in requiring an emergent tracheostomy. So this is something that we routinely do here. And then it's really, really important to cover level 6 nodes in those patients. And then by level 7, I mean the very superior part of the mediastinum going up to the aortic arch. And again, level 4 involvement, subglottic extension, and the apex of the piriform sinus, if that's involved, we should cover these lymph node basins. Retropharyngeal nodes, I almost never cover unless somebody has really, really bulky cervical adenopathy. And if that's the case, then I will cover RP nodes and retrostyloid nodes in these patients. So I wanted to share a couple of cases with you. This is a post-op larynx patient. So this is a patient of mine with T4A disease and 3B disease. So disease with, nodal disease with extra nodal extension. And you can see this is a big tumor. So on surgery, over a 6 centimeter tumor with extralaryngeal extension, there's extensive perineural invasion, there's extensive lymphovascular space invasion, close margin at the distal trachea, and you can see a lot of lymph nodes involved, 16 out of 80 lymph nodes involved. There's gross E&E, and this patient got emergent tracheostomy prior to the surgery. And now when a patient undergoes a laryngectomy and a lymph node dissection, we have to recognize where the lymph node dissection ends. So generally for most patients, they'll dissect supraclavicular lymph nodes and they'll dissect, you're taking out the larynx, so the Delphian lymph nodes are dissected, but, surgeons never really go into the superior mediastinum. And so we always have to be mindful that, that this is not surgically addressed in patients. This is showing you some pre-op imaging. So you can see this very, very bulky larynx cancer. You can see the emergent tracheostomy. You can see here the entire, larynx really is obliterated and the airway is completely obliterated here. And you can see why this patient got a tracheostomy up front. And so this is what, we decided that we would cover. So, highest risk disease really to the area of close margins, E&E. And then intermediate dose volume in a post-op larynx cancer, the entire post-op bed, stoma and tracheostomy site, and all involve lymph node basins. And then low dose, just the elective neck, getting on the order of about 50 gray BED dose. So this is what we decided. As you can see, what we covered. Given this patient had positive margins or E&E, this patient's definitely going to get concurrent chemotherapy. And so in this case, this patient got platinum. And this is just, I wanted to kind of walk you through these volumes. I think as we've learned, looking at oral cavity cases, post-op contouring is a challenge, even for the most seasoned head and neck, expert. These patients, where you don't have any normal anatomic landmarks, especially in the post-surgical setting, especially if you have flaps, becomes really a big challenge of what to cover. And so you can see here, starting at the top, treating level 2 nodes. And then now you can see the yellow is involved lymph node basins as you're coming down into the mid-level neck of left level 2 nodes here. And then you can see as you're coming to the bottom of the mandible, where larynx would have been, now you're covering the entire central compartment. So one of the key things in larynx patients is you're not going to spare the cricopharyngeus. You are not sparing the cervical esophagus. Unfortunately, there's no way to spare this without treating the post-op bed in these patients. So, we don't do a lot of elective G-tubes here in most of our head and neck patients, but these post-op patients oftentimes will have a G-tube placed at the time of surgery because the entire swallowing apparatus is going to be in the radiation fields. Again, now just showing you the central compartment here. You can see that in these patients, we're covering level 5 nodes, because of just extensive nodal involvement. So you can see 5A nodes here being covered. You can see there's bolus placed right along the anterior neck here to cover where the emergent tracheostomy site was. And then you can see coming down here into the neck, and these are surprises. I'm a big fan of IV contrast in most head and neck cancer patients. And this is the reason. So this is a patient where we actually found gross disease right in level 7 lymph nodes. And so you can see that's contoured in red, and that's something that we decided to boost after seeing that there was gross nodal disease in the superior mediastinum. Just showing you some sagittal and coronal planes, and you can see how far inferior this is going. So you really do have to treat into the upper mediastinum for these patients. And you can see the gross disease in red contoured here. So these were unexpected surprises for us in the post-op setting for these patients. So next, we're going to talk about a very unusual histology, small cell carcinoma of the head and neck. So as we all know, we're all used to seeing a lot of small cell lung cancer, but small cell carcinomas can literally arise anywhere else in any other part of the body. And unfortunately, these are actually more aggressive than pulmonary small cell. And so patients that present with small cell carcinomas of the head and neck, these can be either in the head and neck mucosa, so they can be in the oropharynx, they can be in the larynx or the hypopharynx. And then you can certainly see small cell carcinomas of the salivary glands and also small cell carcinomas of nasal cavity and paranasal sinuses. This is generally not surgically, managed. As you know, we treat small cell carcinomas very similar to how we treat small cell carcinomas of the lung. So really the primary treatment is going to be chemoradiation for these patients. And you're going to generally use either cis etoposide or carbo and etoposide for these patients for chemotherapy. One of the other things that I will say, small cell cancers of the head and neck are one of the few histologies that have propensity for brain metastases. So certainly it's important for us to do a brain MRI to make sure, and then again, a staging PET to make sure that there is no distant disease. This patient of mine also had very bulky disease at presentation, in this case, T4 disease, and got emergent tracheostomy. Very, very similar to small cell of the lung. Oftentimes, we'll start with upfront chemotherapy. While you're waiting to see this patient, while you're waiting to simulate and plan this patient, they can start with upfront chemotherapy. And that was the case in this patient. Because small cell is quite sensitive, in this case, I decided to do a bit of a discount on the disease, on the dose to the gross disease. You can see, again, very standard kind of head and neck margins, very standard head and neck contouring, as we talked about in the previous case, really treating all involved nodal basins. And in this case, you can see there was a lot of nodal involvement, which is very, very classic for small cell, where you'll see lymph nodes involving really throughout the neck, and then some elective nodes above and beyond. So this is now showing you an intact larynx patient, and you can kind of get a chance of kind of seeing what these volumes look like. You can see because of how much disease there was, really starting quite high. So you can see, really here's the hyoid covering the preepiglottic fat in this patient. You can see the bulky disease here along the right true vocal cord, so covering all of the larynx, and you can see all of the central compartment here. So the larynx, as well as, really the anterior nodes. So here you can see these are level 3 nodes, all being covered, in the high dose volume because there was gross disease here. And then you can see the elective necks again going to cover the rest of level 3 and even 5A nodes here. Here you can see the cartilage is being obliterated, and so you can see it's quite locally advanced. You can see this patient required an emergent tracheostomy to protect the airway. And you can kind of get a sense of these nodes. And you can see that these nodes, gross disease nodes, really going all the way, quite low into the chest for this patient. Again, showing you these volumes. I'm always, I love showing these sagittal volumes and coronal volumes so you can kind of get a sense of how high we go to treat the elective neck in these patients and how low we go really into the mediastinum to treat elective neck in these patients. So very, very big fields for us as radiation oncologists to treat because you're really treating both head, neck, and the upper part of the chest in these patients. Any questions on larynx cancer?
Yes, we have two questions for the public. Maria asked if you have some consideration for the tracheostomy skin to put bolus or not. What is your think
Yeah,
about
absolutely. I always put bolus. So, it's funny in the VMAT era where you're doing arcs, we all realize that the skin actually gets a lot of dose. And there are places where I take off bolus, or don't use bolus because I know a VMAT plan is going to give skin doses on the order of 80% of my prescription dose. But laryngectomy is one of those, or emergent tracheostomy is one of those indications where I still absolutely we will start with bolus. Now, it is not uncommon for me that after 5 weeks or so, if I start seeing dry desquamation around the tracheostomy, I will take off the bolus.
Okay.
I'll still cover the stoma, I'll still cover the tracheostomy site, but I'll just take off the bolus, after 50 gray or so if I'm starting to see a lot of skin irritation in that area. But always start with bolus.
Perfect. And the next question is, what do you think about the PET for the contouring of the target?
I like PET scans. Honestly, I always think of PET as really functional imaging to kind of show me where the disease is and not necessarily giving me anatomic details. I think in, especially locally advanced head and neck cancers, PET can oftentimes be really helpful in detecting small nodes that may not meet CT criteria for, for being pathologic, but can show uptake in those nodes. And then certainly for distant disease. I will always co-register a PET, but I will contour on CT because I realize that there are inherent problems with registration. Depending on where you are, you may be doing a rigid registration. If you have, access to your team doing deformal registration, it's better. But even with deformable registration, oftentimes I will find, because just the PET is not always in the same position as your treatment planning CT, that you need multiple fusions. And so sometimes I'll tell my team, I want 2 separate fusions, one fusion aligned to, say, the mandible to kind of get the neck feels intact, and the other field aligned to the larynx itself to be able to kind of see where the laryngeal uptake is. So I always rely more on the CT than on any other, tool for the contours, than even more than the PET.
That's true. And this another question is, always you use the level 7 prevascular level?
Always. What a great question. So not for early stage larynx cancers, obviously, if you're just treating the larynx only, but for most locally advanced larynx cancers, I always electively cover level 7 nodes. Because again, as I said, as we realize, just where the larynx is located, really level 3 and 4 nodes are your primary drainage nodes. So level 6, 7 is the first line of secondary drainage, and that's where most patients will fail, if you don't cover those basins. And so this is one of the places where I'm very, very liberal about covering 6 and 7 basins. For this, I always cover 7, as I said, for locally advanced things, and even 6. I for the least of indications, I will cover the pre-Delphian nodes for those patients.
Perfect. You can continue.
All right, next is thyroid cancer, and I will tell you, I'm here to learn from you. I would love for you all to ask questions. I want to see what thyroid patients you're seeing and what patients you're not seeing. So this is a very unusual histology of thyroid cancer called Hürthle cell carcinoma. So this is a woman who had a Hürthle cell carcinoma, as you can see, diagnosed a very, very long time ago, 30 plus years ago. At that time had a hemithyroidectomy and did not get any adjuvant therapy. And just so that we all know, Hürthle cell carcinomas, don't really respond to radioactive iodine generally. So these patients don't get RAI on the back end like differentiated thyroid cancers like papillary or follicular. So then, as you can see, a very, very late relapse in this patient. You can see, almost, just almost 30 years out for this patient, you're seeing this relapse. And you can see, again, now, having a recurrence in the contralateral thyroid lobe with extrathyroidal extension and cervical lymph node involvements. And so this patient then got a completion total thyroidectomy, a neck dissection, and at the time of surgery, there was just extensive disease. There was disease in the tracheoesophageal groove, there was tracheal invasion, there's esophageal invasion, there's gross extrathyroidal extension. As you can imagine, there's positive margins, 1 out of 12 nodes positive. And now the histology is actually a papillary thyroid carcinoma mixed in with the Hürthle cell carcinoma. This is, and the surgeons are not able to take everything out because they wanted to preserve the esophagus, while there's disease left behind along the TE groove. Interestingly, this patient's disease was BRAF positive. So this patient actually got, anti-BRAF therapy, so dabrafenib. And, so this was the upfront therapy. So again, this is just for cytoreduction. This patient got, the systemic therapy, had some reduction. And then actually this patient went back for another surgery and now gets a central compartment resection. And the thoracic surgeons go in and do a superior mediastinal resection, right? Remember, head and neck surgeons are not going to be able to do that because they really you need a sternotomy to be able to kind of go in and access the superior mediastinum. They resect additional disease, as you can see. So very, very heroic surgery, something that doesn't happen even here routinely. It would be very hard to do this kind of surgery in most places across the world, but now has an R0 resection. So before we jump to thyroid cancer, and I know we're talking about a couple of different histologies here, but the most common thyroid cancers we see are papillary and follicular. So my question for all of you is, when do you think of adding external beam radiation after radioactive iodine in these patients?
We have residual central compartment disease, like 50% of the people. Some people put a positive margin. Yeah, residual central compartment disease.
Yeah. So
Yeah.
that is the correct answer, but you can see that this is harder. This is a harder
Yes.
question for all of us. So I will say, so that's the correct answer. So for a differentiated thyroid cancer patient, those classic indications where we routinely add external beam radiation for all other post-op head and neck cancers, things like positive margins, things like positive lymph nodes, things like even, extranodal extension, are really not upfront indications for adding external beam radiation. And so the only classic indication where you should think about it is when you have residual disease in the central compartment. So, disease that is, really an R2 resection where you're leaving disease. And generally the most common site where surgeons will leave disease is the tracheoesophageal groove, to be able to leave an intact esophagus for the patient to be able to swallow, as well as the trachea. So that's the most common referral that we get. I will tell you, even this, many of us just don't see these patients. So it is not uncommon that the vast majority of patients with differentiated thyroid cancer that we're seeing are at the time of second and third relapses. We know that we're not treating them in the upfront setting. In the US, there are a handful of centers that are very, very aggressive about treating patients at initial presentation for central compartment disease. And those really are, really MD Anderson probably is the most aggressive for those patients, but most of the other places we're not seeing these patients. So there we go. I wanted to kind of talk about, I generally think that external beam radiation is controversial. There are no textbook, answers for this. Really depends. I think we all agree when to use postoperative radiation, external beam radiation routinely, certainly in anaplastic thyroid cancers. And then there's, over the last 15 years or so, there's a recognition of this new histology in thyroid cancers. And these are patients with poorly differentiated thyroid cancers. And poorly differentiated thyroid cancers happen in one of two situations. They are either de novo, where the patient just upfront has a very poorly differentiated thyroid cancer that is neither a follicular, where you can't identify it's either of a follicular origin or a papillary origin. Or the other circumstance where you see this histology is that somebody who has a long-standing history of either papillary or follicular thyroid cancers, over decades, they can transform into this poorly differentiated histology where the cells are just no longer as, RAI avid. The 5-year survival, we all know anaplastic thyroid cancer, 5-year survival is 0. Most of these patients unfortunately die within 1 to 2 years of diagnosis. Poorly differentiated thyroid cancer does not do very well either. The 5-year overall survival for these patients really is on the order of 20 to 30%. And the vast majority of these patients get distant disease and die of metastatic disease. So it's just something for us to be mindful of. Again, these are not very common, but if you ever see these, when in doubt, add external beam radiation for these patients, because even central neck failure, so local regional failures, are a big issue, very similar to anaplastic thyroid patients. For things like medullary thyroid cancer, we certainly talk about using postoperative radiation in high-risk patients. Similarly, for Hürthle cell, we talk about using external beam radiation in high-risk patients because these patients really don't have radioactive iodine as an option. But in terms of differentiated thyroid cancers, kind of the classic times where I think we all see these patients, talked about the R2 patients, the residual central compartment disease where gross disease is left behind. Multiple recurrences, really after a second recurrence, so their third time getting this cancer, something that, even with the best surgery, I start thinking that maybe I need to add external beam, especially if they've had 1 to 2 courses of prior RAI. Sometimes we'll hear from endocrinologists that the disease is just RAI refractory, so we'll add external beam radiation for those patients. And then finally, as I mentioned, is this de-differentiation of a previously well-differentiated histology. So this is exactly what I was mentioning. This is that secondary presentation of a poorly differentiated thyroid cancer, where I think of adding radiation for these patients. Just showing some anatomy for thyroids, I think you kind of get a sense. So here's, the 2 lobes of the thyroid gland. Here's the isthmus connecting them. Level 6 lymph nodes are going to be anterior to that. And then you can see trachea. Here's the esophagus. Here is the tracheoesophageal groove. It's right along here. And so you can see it is a very tough place for even surgeons to go in and anatomically clear. And then here you kind of get an idea of the central compartment. So other issues that are going to come into play, as you can imagine, our scalene muscles are right here. So the brachial plexus is going to run right underneath there. So oftentimes the brachial plexus also is, you're going to have some portion of the brachial plexus in your central compartment neck fields for these patients. What to treat in thyroid cancer, gross disease, we try to go to 70 gray. I will tell you, this is very, very challenging, even for me, to get 70 gray in, especially disease in the tracheoesophageal groove. It's, very stressful to irradiate the esophagus to 70 gray. I'm always worried about leaving the patient with a, permanent G-tube in that situation. So it's not uncommon for all of us, even here, to stop at like 64 to 66 gray, even for gross disease, because of those considerations. Obviously, positive margins, positive E&E, you're going to go to somewhere between 63 and 66 gray. And then again, treating that high-risk volume, which is the central compartment for these patients, including the TE groove and any involved lymph node basins, to at least 60 gray. And then low-risk, basins, again, kind of treating to, 50 gray biologic equivalent. I think one of the key things is the cranial border of your cervical nodes is very, very controversial. For most patients, you don't need to go all the way up to the skull base. Oftentimes, we actually even just treat up to the transverse process of C2. And what this allows you to do, especially if on one side you're node negative, is that you can spare the entire parotid gland for these patients on that side. Now, if you have nodal involvement on that side, my general rule of thumb is to at least treat 1 to 2 centimeters higher, above where the highest lymph node basin was involved, to cover that in those patients. So here's that patient I was talking about, adjuvant RT followed by RAI. I just wanted to kind of show you, so for this patient, so, what we treated. So here you can see in yellow is the central compartment. In blue are all the elective lymph node basins. And so you can see here in a thyroid patient, you have to cover 5A and 5B because it's going to be literally abutting the central compartment for these patients. And you can see there was gross disease right here in the TE groove. I had an MR to help delineate really the gross disease for this patient. You can craniocaudally kind of get that, idea of where that gross disease is. So you can see, very tricky area for us to radiate. And unfortunately, in this patient, she actually had distant disease very quickly after this, but just giving you an idea of just, where we're contouring for these patients. Again, just showing you some volumes. So you can see, starting to cover level 6 nodes pretty high up. You can see the nodal basins. You can see the vast majority of the larynx ends up being in the field for these patients, just to give margin. And you can kind of get an idea of and you can see the superior mediastinum just contouring those lymph node basins here for those patients. And this is what this looks like. So the key thing I want to point out is that we spared in this patient bilateral kind of parotid glands. You can see they're completely out of the radiation field. So by starting a bit lower in the neck, and so you can see, I only treated a couple of centimeters above where the patient had involved nodal disease, and really spared majority of the mouth, oral cavity here, as well as the parotid glands in this patient. Next, I'm going to talk about anaplastic thyroid cancer case. These, I will tell you, in the past 16 years, I've been treating head and neck cancer patients. I have never successfully, I don't think, treated a patient through 6 weeks of adjuvant radiation. It's very, very unlikely. These patients are so challenging to treat. And the question, I still am not convinced of what the right sequencing of therapies is in anaplastic thyroid cancer patients. There are places now that start with upfront chemoradiation, like a pre-op approach. There are places that still go with upfront surgery and then followed by post-op chemoradiation. And you can see that, surgery in these patients is fraught with issues. There's oftentimes residual disease left behind. I just put the op note in for you to get an idea of, how aggressive this disease is. And of all head and neck cancers where you think of rapid doubling times, right? So I treat primarily head and neck and heme malignancies and in lymphomas, high-grade lymphomas like mantle cell lymphoma, Burkitt's lymphoma, they can double within hours, where the nodal disease is just rapidly doubling. The only head and neck cancer I've ever seen nodal, just disease double within the matter of days is these anaplastic thyroid cancer patients. They have a very, very high Ki-67 index. So these are patients, when you're looking at how to treat these patients beyond just contouring and delivery, these are patients, in my opinion, one of the few that really benefit from daily cone beam CTs for your setup, because it is not uncommon. I will tell you that we routinely see where we contour and within 2 or 3 weeks, their disease is way beyond what we're treating. And so I think this, adaptive radiotherapy really has a role for this patient. I'm showing you one of my post-op cases. So you can see this patient has a lot of gross disease left behind. Just showing you these volumes. So these volumes are not very surprising. You all kind of get a sense. I wanted to kind of really focus on just the central compartment for this talk. So you can see treating all of that central compartment here. You can see the gross disease here in these patients, treating all of this here. And, the gross disease going all the way down into that superior mediastinum. Okay, so this is again showing you, and this is a post-op case. They tried to debulk, they went in, they abandoned very, very quickly, which is not uncommon, where surgeons will think that they can resect some of this and realize they can't resect most of this. And even in this patient, I will tell you, by week 5, they had progressed outside of my radiation fields. So not uncommon. So this is where I think the daily cone beam CTs are very, very helpful. Questions about thyroid cancer?
Yes, Dr. Parag, a lot of questions in the public. The first question is, what is the constraint for the nerve, recurrent nerve, if you use 70 grade for
Great
the
question, 70 gray.
Yeah.
I don't discount. That's a great question. I know for all the physicists and dosimetrists on the call, I know we obsess about brachial plexus tolerances and, just cranial nerve tolerances, where we're all taught 63 to 66 gray. And this is a big issue. And I will say that every time, we are very spoiled here. We do disease-specific chart rounds, but sometimes I'll sit in on a breast chart round for whatever reason, and I'll hear the breast team go on and on and on about brachial plexus dose of how they want to not go beyond 60 gray, right? They're very, very conservative. And I get that because, again, breast cancer, vastly curable, local regional recurrence after radiation is not a big problem. Head and neck cancer is a completely different beast. In head and neck cancer, we are the primary modality for cure. So, I generally just say, tolerance is 70 gray. Brachial plexopathy in head and neck cancer patients, and I'm going to knock on some wood here, is generally not very common. Unlike breast cancer patients where, there are lots of series documenting brachial plexopathy 10, 20 years out. In head and neck cancer, we just don't see that. Part of it is that perhaps a lot of patients, especially that, with locally advanced non-HPV related head and neck cancer, don't live 10 to 20 years because they have competing risks. So even if they're cured of their head and neck cancer, they're generally an older cohort of patients. If they have smoking as a risk factor, they get lung cancer. So that's one of the issues, I think, that we don't see those toxicities. But generally, I would cover that to full dose. I really don't discount that.
Okay, thank you. And the next question is, in the medullary, the adjuvancy you recommended in those case.
Yeah, I will say, so for medullary thyroid cancers, because they don't really take radioactive iodine, I think I follow kind of the classic principles of where you recommend post-op radiation. So patients with T3, T4 disease, close or positive margins or residual disease, nodal disease, extranodal extension, lymphovascular space invasion, perineural invasion, any of those risk factors where you'd be thinking of adding post-op RT in a otherwise mucosal primary, I do recommend it.
Okay, thank you. And there is another question: in patients with a papillary or follicular no disease or bulky, do you offer radical radiotherapy?
So after surgery?
If not surgery, no
Oh,
surgery.
no surgery. Yeah, absolutely. So I think one of the things about differentiated thyroid cancer, so if you have somebody who's medically unresectable or at recurrence is unresectable, I do think that radiation is a very important modality for local regional control. Now, unlike other head and neck cancers, with squamous cell carcinomas, right, we cure patients, tumors shrink, they go away. in papillary and follicular thyroid cancers, because they're differentiated and so slowly growing, radiation really is just tumorostatic. So I think the most important thing is telling the patients the goal of the radiation is to arrest your disease to where it is today. Involution, in our experience, and I think most series, is very, very rare, right? So it's on the order of like maybe 15 to 20% will actually have true involution of their disease. But I think radiation is really important. I think for places, where you have access to, essentially targeted drugs, right? So lenvatinib, which is it's a kind of a TKI with EGFR inhibition, is kind of the classic drug used for differentiated thyroid cancer. So, some of your patients, if you have access to that, may get that. But even with lenvatinib doesn't really cause a lot of tumor involution. It really, at best, is just tumorostatic, and that drug also has a fair number of side effects. So sometimes I will, start with lenvatinib in a patient to see for 3 to 6 months to see if there's any involution before I go to external beam radiation. But I generally think that external beam radiation is an important part of therapy for those patients.
Okay, and the last question: in pathologies with poor prognosis, what do you think about the partial thyroid surgery or boost surgery?
Yeah, great question. I think for poorly differentiated thyroid cancers, because patients do live on the order of 2 to 5 years, I still prefer surgery whenever possible. I will tell you, and I have no literature to back this, but for anaplastic thyroid cancers, I routinely question all therapies and to see, what are we really doing? Are we really helping people? Because even putting patients through, if thyroidectomy is anatomically feasible and is a clear, like, yes, it's low volume anaplastic thyroid cancer, they're going to be able to get surgery in, I think that makes sense. As I said, for a lot of patients, I think, it's not uncommon for the surgeons to go in and abandon surgery after they see what's going, when they open the patient's neck. The question becomes, what is the right treatment? Honestly, even in radiation, I always question, is standard fractionation the right answer? Probably not. These patients live on the order of 6 months to a year. So to put them through 7 weeks of treatment in your department just seems like a lot of time. So I think this is where I think hypofractionation is very, very reasonable. So, doing, giving 2.5 to 3 gray per fractions and shrinking the radiation course from 7 weeks down to 4 weeks is very, very reasonable for these patients. So something for all of us to consider.
Okay, thank you. Continue.
All right. Next, we're going to talk about sinonasal cancer.
Dr. Ornelas have a question.
Okay, let's do
I
that.
don't know.
Sorry, I can speak Spanish or only I need to talk in English?
Puedes hacer la pregunta en español y nosotros podemos traducirla en inglés.
Ok, yo me ha tocado tratar pacientes con cáncer de tiroides durante varios tiempos. Yo trato aproximadamente 200 pacientes con cáncer de tiroides al año. Y pues ves todas las variantes y todo lo que pasa. Y últimamente hemos estado notando con ciertos cirujanos que cuando nosotros damos un tratamiento de yodo y después damos un tratamiento de radioterapia en un periodo aproximado de 3 meses, los pacientes han tenido un mejor pronóstico. Incluso cuando el cirujano llega a necesidad, tiene la oportunidad de entrar a cirugía, ha tenido unas resecciones más completas y con un mejor pronóstico y menos morbilidad. Los pacientes anaplásicos en realidad es un reto, pero también con ellos el tratamiento sí se tiene que ajustar muy bien en tiempo, porque de cuenta, también hemos tenido situaciones que no responden al tratamiento de radioterapia, no responden a todo lo que se le hace, pero siempre es mejor la mayor parte que pueda resecar el cirujano para después darle el tratamiento subsecuente, ya sea con yodo o con radioterapia, porque cuando quedan enfermedades muy voluminosas, a veces es muy complicado tratarlos. Entonces, eso que ustedes están mencionando, sí es bueno que si se le va a otorgar un tratamiento a un cáncer de tiroides, sí a veces es bueno darle primero yodo, después radioterapia en un periodo de 2 a 3 meses y posteriormente que termine el periodo de radioterapia, poder evaluar sí es candidato a tratamiento quirúrgico y sí ha tenido mejor pronóstico. Honestamente, hemos tenido pacientes con una lesión de aproximadamente 10, 15 centímetros y hemos seguido este proceso de primero yodo, luego radio y hemos llegado a tener resecciones completas con bordes negativos.
Ya, es reflexión, ¿no? Dr. Parag? Hi. Yeah, you understand? You have a translation of the question? Or?
I put the summary in the chat, but Dr. Ornelas treats many thyroid cancer patients, like 200 a year, and he's found a strategy that has worked actually quite well of giving iridium 131, and then
external beam radiation. No, so
2 or 3 months later, yeah.
It's such an institutional practice. I actually think that that is a fantastic strategy if you can get your surgeons and endocrinologists to buy into that. So I will say that for a lot of our thyroid cancer patients that have high risk features, with, as I mentioned, for differentiated thyroid cancer that has central compartment disease that was an R1 resection, we are also more and more pushing for exactly this approach, where we start with radioactive iodine and then give external beam radiation, several months later. And I think that this approach makes a lot of sense because, it's nice to give the RAI first logistically from a radiation oncologist point of view, because you can then give them iodinated contrast after the RAI. You can't do that before the RAI because then that's going to screw up their RAI delivery. But I think that this is a fantastic approach. I think that I inherently believe that this would work, because it makes sense to use radiation to really give, add to local regional control for these patients. I see it has to be a differentiated thyroid cancer for this approach to work. I will just say that, in places, I think that it's just, we have a very large thyroid volume here at UCSD. We see a lot of thyroid cancer patients. And so for the vast majority of patients, especially in their 30s and 40s, which is our most common demographic, 30 to 40-year-old woman with differentiated thyroid cancer, it's hard, hard to push external beam radiation at that young age if they're getting radioactive iodine. But at the time of first or second recurrence, I'm a big proponent of this, and I will oftentimes do exactly the approach outlined by Dr. Ornelas, where I will say, let's do one more course of RAI and follow that by external beam. So great points. Thank you.
And there is another question. If you have a medullary cancer stage 4 for a lung metastasis with a big tumoral activity in neck with dysphagia, but they have a code 1, yeah, the good status performance. Do you treat it in palliative context with a skin hyperfractionated only with a mass or the nodes too?
Great question. Great. I think that maybe in one of these years we should add a talk on just palliative head and neck radiation, because this is a lot of what we see. And I will tell you, these are the hardest cases I have ever on my service. So I will just say that for oligometastatic head and neck cancer, whether it's thyroid or not, I think that local regional control becomes so important that I do think that aggressive local regional radiation is the right answer. Now, the question is, so 2 questions, I'll answer both of them. One is, do I treat with, what type of doses do I treat to, right? So definitive intent doses versus palliative intent doses. I think that line gets very, very blurry. I will say that my preferred approach, and even here, I think just our head and neck team, the preferred approach in somebody who has good performance status and low volume metastatic disease is to treat them with modest hypofractionation, but almost to curative intent doses. So what do I mean by that? 50 to 57.5 gray and 20 to 23 fractions to the gross disease, which is biologically going to be very, very close to 70 gray and 35 fractions. Okay. Now, the question of elective nodal radiation in those patients comes up. I think that is, to me, the harder part. I really base it on histology and life expectancy, whether I add elective neck or not. I literally right now have a very aggressive neuroendocrine patient with disease going in through the skull base into the brain, and then with a single lung metastasis. And literally this week I was faced with the same question of what am I going to treat and how high am I going to treat? Because it was a neuroendocrine tumor and the risk of nodal metastasis is so high, I did end up treating the elective nodes, to some dose. So I think what I like about the 2.5 or even 2.75 gray per fraction is you can do an SIB at 2 gray per fraction and treat the elective neck to 40 to 45 gray, which is a really good dose for, microscopic disease in the neck.
Yes. Thank you. Dr. David?
Thanks, Sarah. Parag, maybe going back to the answer that you have given us before, what dose would you use for the combination strategy with iodine and EBRT? And maybe we can listen also the Dr. Ornella's approach, because this is a question that we have already in the chat as well.
Okay. Dr. Ornelas, do you want to start?
Dr. Ornelas, we can listen to you right now.
Can you repeat me the question, please?
¿Cuál es la combinación o la estrategia de dosimetría o de dosis que usted utiliza cuando hace la combinación con el yodo y radioterapia externa?
Now we only use the normal hyperfractionation,
¿Cuánta dosis de yodo?
Nosotros en la primera dosis del paciente, cuando es un paciente que se cumplen los requisitos, que no tiene tomografía, ni tiene ningún otro tratamiento que se haya utilizado yodo o algún estudio, la primera dosis que damos es de 150 milicuris. Y las dosis, si el paciente llega a hacer algún tratamiento subsecuente, entonces ya las dosis las utilizamos en menor dosis del tamaño que se le da. Se puede dar una dosis de 100 y el paciente puede tener un control de 2 a 3 años, o incluso hasta mayor tiempo, dependiendo del paciente.
Dr. Parag, you can switch over to the English channel.
Yeah.
Okay.
Okay, thank you, doctor, for the explication. We can continue.
Sir, but maybe Parag can give us his answer as well.
Okay. Dr. Parag, Dr. Ornella said that they use before the radiation therapy approximately 150 jod therapy previously to the dose of radiotherapy, and he used 2 volumes, 70 grade, 54 grade to the elective nodes.
Yeah, great. Yeah, so typically, exactly, the RAI doses are somewhere between 120 and 160 millicuries in patients. And so I think that we use very similar doses for RAI. The timing, I'm actually curious, I think it's nice to wait 3 months. I think that makes sense for a differentiated thyroid cancer to wait a little bit to allow them to recover from the acute side effects of RAI, especially if it affects their counts a little bit. And then for external beam doses, so I think here we're a little bit more conservative on the dose to gross disease. So generally for most patients, especially with differentiated thyroid cancers, we feel pretty comfortable stopping at 64 to 66 gray and then taking the elective neck to, BED of 50 gray. So 54 gray makes perfect sense in treating those patients. I think, as Dr. Arnalas was saying, I think, the key thing is just being very comprehensive in irradiating the right volumes for thyroid cancer patients. So being very mindful of kind of treating that central compartment, treating level 6 and 7 nodes for those patients. Thank you, everybody. Great discussion, great learning, because obviously this is great to hear from somebody who does a lot more of this than even I do. Next, we're going to end by talking about sinonasal cancers. And we all know that these are very, very challenging malignancies with over a dozen different histologies that we see. I have one poll, and then I'm going to actually ask a question because as I was thinking about this case. So this is a patient with locally advanced neuroendocrine carcinoma, and you can see it involves nasal cavity, ethmoid sinus, sphenoid sinus, orbital invasion, maxillary sinus invasion, and then anterior cranial fossa invasion. So really going through the skull base. And you can imagine that this patient, because of the anatomic involvement, really got an R2 resection. This case is a couple of years old, and I will tell you that now we've even changed our practice here as to how we approach these patients. But let's talk about this patient first, and then we'll talk about kind of what what we do today. So this patient got, again, neuroendocrine carcinoma, so definitely starting with chemotherapy while you're waiting to evaluate and simulate the patient. So this patient got a couple of cycles of cis-etoposide and then came in to get chemoradiation as adjuvant therapy. Now, the issue in this patient with the complexity is just the area where the residual disease was, which made it very difficult to get all that dose in with an external beam radiation plan. And so this is one of the things I wanted to talk about. So when we see these really high volume disease patients with T4 disease going through the skull base, going into the anterior cranial fossa or cavernous sinus, oftentimes, especially, if they're node negative, we'll start with a upfront plan of kind of going to a dose that we want the elective nodes to take. So in this case, this is an SIB plan. I wanted to treat the elective neck to about 50 gray equivalent. So you can see 54 gray. So 1.8 to 54 gray, and then doing a, SIB at 2 gray to 60 gray. And in these patients, especially neuroendocrine patients, I also like the approach where you can do a interim CT, midway around week 3, week 4, to see if there's involution, because that neuroendocrine cancers respond very well both to chemotherapy and radiation. So if you can get tumor involution, you can use that to your advantage as you decide how to boost these patients. All right, I do have a question here. So this is a poll for everybody. It's just, what are the most common histologies for minor salivary gland cancers of nasal cavity and paranasal sinuses?
Okay, very near mucoepidermoid carcinoma and adenocystic carcinoma. It's 45, 40, 38. Yeah, so close.
Okay, so you can see, so this is a great question really for all the trainees when you take your exams. It's a very, very common question. So, so as you all know, mucoepidermoid carcinomas are the most common carcinomas of the salivary glands, but in minor salivary glands, it is actually adenoid cystic carcinomas. They're more common. So answer B is correct for these patients. And so, but mucoepidermoid definitely very, very common, but not as common as adenoid cystic carcinomas. So just want to talk about just paranasal sinuses. Very, very complex anatomy. I think we all get these patients. The biggest issues that I think that face us as radiation oncologists is when we start seeing orbital and intracranial invasion for these patients. Just in this location, perineural spread is actually quite common, which is why these tumors end up, kind of in the, especially V2 involvement. So the maxillary branch of the trigeminal nerve being involved is very common in these patients that you'll see. And then lymphatic drainage actually for nasal cavity paranasal sinuses is somewhat lower than what you would see in a mucosal head and neck cancer. So unless the tumor spreads into nasal cavity, nasopharynx, or skin, it's not uncommon for all of us to see these patients that have T4 disease at presentation with no lymph node involvement for these patients. In terms of what to cover, it really depends on the location of where the disease is and a bit on the histology. So I think those are the two things I take into account. What is the histology of the tumor? So if I know somebody has an adenoid cystic carcinoma, I'm very, very keen to cover the perineural pathways. And then really otherwise basing on the location of the gross disease. So if you have tumor involving the maxillary sinus, certainly, covering, all of the maxillary sinus, in the post-op setting, covering all of the resection bed. You have to cover, inferiorly going into the maxilla and the hard palate. Superiorly, you're going at least up to the cribriform plate. Laterally, if you have maxillary sinus involvement, you really need to cover that ipsilateral portion of the nasal cavity, so going to the midline nasal septum. And then posteriorly, really covering the path of V2, so covering the pterygopalatine fossa and then being generous in the infratemporal fossa. As I mentioned, depending on the histology, so neuroendocrine or adenoid cystic, I'm going to be very keen about covering the V2 pathway. Ethmoid sinus tumors, these are very, very challenging because you're going to cover all of the cribriform plate. You are going to cover at least, some volume into the frontal sinus. You need an MRI to make sure there's no violation of the frontal sinus where disease is going into the anterior dura. Inferiorly, you're covering all the way down to the inferior turbinate. So ethmoid sinuses are in direct communication, as you can see, with the nasal cavity. So got to cover the nasal cavity. And then you can see, laterally again, covering the nasal cavity, ethmoid sinus, and the ipsilateral maxillary sinus. And then posteriorly, ethmoid sinus is covering the sphenoid sinuses. And, the first echelon for ethmoid sinus location is the RP lymph nodes. So being mindful of covering those. Just showing you some pictures here, just kind of, you can see, just showing you the anatomy here of kind of where things are. The skull base and cranial nerve foramina become really, really important. So here you can see in this patient, foramen rotundum coming in. You can see the pterygopalatine fossa right here covering. And so you can see why we have to cover this so generously. And then as you're covering the sinuses, you're oftentimes covering that medial wall of the orbit, which makes it really anatomically challenging for our dosimetry and physics colleagues to give you a plan where you're covering all of that area, yet sparing the globe, sparing the retina, sparing the optic nerve in these patients. Also showing you, superior orbital fissure here. I just wanted to put this picture in to show you the cranial nerve foramina that really come into play for a lot of these patients. So things like superior orbital fissure, foramen rotundum, Viridian canal, pterygopalatine fossa, and foramen ovale. This is this patient, again, kind of showing you these volumes. So you can see, very generously covering the frontal sinus. I'm actually covering some of the dura. And this in orange is where there's disease left behind. And you can kind of get a sense of these volumes, pretty big volumes. So yellow is the post-op bed, red and orange are kind of where the disease is left behind. And then basically the magenta is my elective volume in this patient. And so you can kind of get a sense of this disease. This patient at the, up front had anterior nasal cavity involvement. And so what you can see here is that I'm covering buccofacial nodes in this patient, in addition to covering kind of level 2 and then level 1 nodes in this patient. So, really comprehensive nodal radiation for this patient. And so here's a nice kind of sagittal view. You can see the big elective volume here. The magenta is where the resection bed was, and then the yellow is where there's gross disease left behind in this patient. Now, in these patients, so what happens is I initially gave 60 gray, and then I wanted to come back and boost this to gross, kind of 70 gray biologic equivalent. And what I ended up doing is kind of creating these two separate volumes. There's an intracranial volume here where there's disease. So yellow is where there's disease. And then the red is my kind of overall PTV here. And so there are two volumes created. So same volume. And I essentially arbitrarily kind of drew a line at the skull base and then decided to treat this with a stereotactic boost. So this patient underwent a repeat CT at week 5. So after they, get their initial 60 gray, this is the stereotactic boost, and we work very, very closely with our physics team to then give us very good EQD2 tables of tolerance of all the structures around there. So the dose for the superior, this is actually flipped, I'm sorry. So this is inferior part is getting 2.5 gray times 4, and the superior part, so intracranial part, is getting 1.8 gray times 4, okay? But we base this basically on tolerances. So in this case, the dosing is completely based for the intracranial part, protecting the optic nerve, protecting the retina and the globe in the brain. And so you can see that's why that dose is modest. And this is where I do think using non-coplanar arcs with a stereotactic plan for the boost is very, very helpful in giving you, maximal dose sparing for these patients. So just showing you this challenging case, but I will tell you in 2024, I would treat this completely differently. So for sinonasal undifferentiated cancers and now for sinonasal neuroendocrine cancer, so SNUC and SNUC, really the pattern of practice, at least in the US over the last 5 years, has evolved based on the MD Anderson series, where we actually start with these patients to get upfront neoadjuvant chemotherapy. So if you are a patient with neuroendocrine cancer, you're getting cis etoposide. If you're a patient with, a SNUC, you're oftentimes getting, cisplatin and gemcitabine. And we give these patients 2 cycles of upfront chemotherapy, and then we re-image them. So we do an MRI and a CT right after those 2 cycles of therapy. If you have a partial response or better, you go on to a primary chemoradiation approach. If you have, no response, so stable disease or progression, then we put these patients through surgery. And I can send the MD Anderson series to everybody later. I should have put this on there, but it has really good concordance of saying that responders do really well with primary chemoradiation without surgery. And non-responders really need surgery followed by additional adjuvant chemoradiation in those patients. So something to be, consider in those patients when you see these very, very locally advanced sinonasal cancers.